I am talking today about the transorbital corridor to the skull base. No disclosures at all. And then just kind of an outline for the talk this morning. Do a brief introduction as well as history of the transorbital approach, review of the current literature and applications, and then I'm going to present some of the data from the cases we completed at the Medical College of Wisconsin, as well as some case examples at the end, bearing some time. So the eyes are the window to your soul is a common saying that has a lot of people that were claim or are associated with saying that. Cicero, which was a Roman philosopher, the Bibles get credited with it, even Shakespeare, Da Vinci, or the French poet Du Bartas. Well, that may be some controversy of who started saying that. What I'm hoping to show is that it can be a window to the anterior middle skull base, as well as the paracellular and paracellular region, the cavernous sinus and orbital apex, just to name a few. Kind of in general, minimally invasive approaches, there's pros and cons. Pros being can be cosmetic, decreased morbidity, decreased hospital stay, which in turn decreases cost both to the hospital and to the patient. Cons could be a learning curve. You're working in small corridors. You may not be able to get the extent of resection via a larger opening approach, as well as OR time. If you are working through a smaller area, could lead to increased OR time. So here's like the rationale for using a transorbital approach kind of in a general sense. Decreased manipulation of the basal frontal lobes, and injury to the orbital frontal as well as the medial basal cortices can lead to amnesia, disinhibition, altered cognition, processing, decision-making for these patients. Another rationale is mentioned the improved cosmetic result. Essentially, the incision is hidden, and then you don't have the temporalis wasting that you would via an open transcranial approach. Cosmetic results aren't necessarily that important to a lot of patients, but some patients they are, so that we take that into consideration as well. And then reduce healing time and decrease length of stay in the hospital as well. So here's a nice illustration kind of showing the three, or I guess the two workhorse transcranial approaches, as well as the transorbital approach, showing the incision on the picture on the left, and then what the craniotomy would be on the right, just to get a sense of the three main approaches to get to these areas of the skull base. This is also a very nice diagram showing the kind of intraorbital corridors, as well as the intracranial access points to get there. So kind of starting at the top is more of a lateral view into the orbit of a dry skull, and the bottom is kind of more of a head-on. The top, if you focus on the white outlines, you can get to the anterior cranial fossa through the roof of the orbit, the frontal sinus kind of in the medial upper pole, ethmoid sinuses, maxillary sinus, infratemporal fossa, temporal fossa, middle cranial fossa, all through there. And then the color coding is nice too, because that kind of shows the different incisions or access points through the orbit to get to those bony landmarks. Blue being a super eyelid approach, the yellow being a preauricular, the red being more of a lateral retrocanthal, and then the orange being a inferior eyelid approach. So recently, if you look at the PubMed and search transorbital approach just in general, you can kind of see that early in the 50s, there's a few publications, and then it's kind of leveled off until right around 2010, which is an important date for this department too, because of that paper that I'll be talking about a little bit later. But it's been exponential since then, with the kind of the surge in the COVID years of publications, and then will continue as we kind of progress. So this is definitely a topic that is getting a lot of notoriety and get a lot of papers out there at this point, and institutions are kind of modifying the technique and kind of adding to the literature out there right now. So we all have seen probably Scott's parabola. So is this something that's kind of going to fall along that curve where we have a promising idea, kind of has a strong pressure for acceptance, and then becomes a standard of treatment, and then essentially falls into disuse and isn't done anymore? Or is it something that's here to stay long term? Kind of on this bottom diagram where we have this kind of peak of expectations, there is a trough of disillusionment, and then will we end up at this plateau of productivity where this approach can essentially be used in the right patients, the right type of pathology, and be here to stay long term. So as with anything, I think knowing the history of where we are today really helps kind of understand the potential, as well as kind of give credit to those who started this years and years ago. So obviously being through the orbit, there was a lot of ophthalmology influence early on in the 1800s. 1874, Hermann Knapp, he was a German ophthalmologist that ended up immigrating to New York. And he was one of the first to describe kind of an anterior orbitotomy for an optic nerve carcinoma back in that day. And then a few years later, Rudolf Krolin, which is a name that many may know, was a Swiss ophthalmologist who really popularized the lateral orbitotomy for tumors in the retrobulbar space. And the diagram here on the right is actually an illustration from his text in 1889, kind of showing the bony removal for the lateral orbitotomy that he used. Fast forward several decades to the 1940s with William Benedict, who really further popularized the lateral orbitotomy. And then in the 50s with Raymond Burke, another name that may be recognized by some here. He worked kind of the same period as Walter Dandy, and often had kind of opposing viewpoints on what the best approach is for orbital tumors, especially ones that went into the intracranial space. And in the 70s, James Galbraith and John Sullivan to kind of further popularize a transorbital approach, mainly for orbital tumors as well. So now going to the neurosurgery influence that kind of parallels the ophthalmology kind of progression of a transorbital approach. Starting in 1913, Charles Fraser kind of explored going through the orbit to get to the sella, saying that he wanted a better approach. To this diagram is also from his text from 1913. Interesting choice of incision going down on the forehead, but you can see the diagram there exposing the optic nerve, and then is getting to the sella kind of through a supraorbital transorbital approach there. And then in the 1940s, I mentioned overlapped with Raymond Burke, was Walter Dandy. He was pretty vocal on his opinion that orbital tumors with especially transcranial extension, the best approach is from a transcranial method, which makes sense given the benefit of pursuing a transorbital approach definitely had negatives in that era, the narrow dimensions that you're working in, the kind of the poor visualization and magnification at that time. Essentially, the microscopes weren't quite used yet, as well as the crudeness of the instruments. Not a lot of micro instruments were developed kind of early in that career yet. So there was a lot of hesitation to go through the orbit where you're working through a smaller space and dealing with some big tumors. And then interestingly, in the 40s and 50s, Walter Freeman popularized the transorbital lobotomy, which I kind of reading up on this, it was gained a lot of notoriety and then a quick demise due to patient outcomes, as well as a lot of negative media feedback, obviously from this type of kind of barbaric, I guess you'd say, approach to treating psychological disorders. So that essentially stunned the progress of the transorbital approach from the neurosurgery side, kind of in the 50s there. Fast forward again to the 70s, which is essentially what we know as the growth of the modern craniotomy technique, microscope, micro instruments. There's lots of names here that we give credit to, kind of the giants in the field. I'm not going to touch too much based on that. And then in the 80s, we started being introduced to the supraorbital approach with J.A. Jane. the orbital craniotomy by Habuka, which is essentially combining Crowling's lateral orbitotomy with a frontal temporal craniotomy. So going back to the ophthalmology influence from the 1800s. Now getting to kind of the modern era, where the endoscopy revolution and the ENT influence is really seen. In the 1980s, John Norris and Gilbert Cleasby were the first reported case of endoscopic assisted orbital surgery. And then in the 2000s, beyond the scope of this talk, but that's really when the proficiency and popularity of the cranial and transnasal endoscopy really took off, both ENT and neurosurgery collaborating. And then a talk at one of the meetings in 2007 was kind of the first display of this transorbital neuroendoscopic surgery, which, as we all know, Chris Moe, Dr. Ellenbogen, I'll talk more about that paper later on in the talk, but really show that the sino-orbital cranial interface can have good visualization as well as good outcomes going through this transorbital approach. And there's a very nice diagram here that in a recent publication in Journal of Neurosurgery that kind of shows the different stages of difficulty for this transorbital approach, being fixing CSF leaks all the way to taking some pretty involved tumors on the skull base, going from stage 1 to stage 5. And as now we're kind of transitioning, I'm going to show a couple slides, or like a slide of some of my favorite places or activities to do. This is White Sand Lake in Buller Junction, Wisconsin, which is in the very northern parts of Wisconsin, kind of right before you get to the Upper Peninsula of Michigan. So now we're going to talk about kind of what the current literature and applications for the transorbital approach is in today's world. As mentioned, this is one of the landmark papers that really started the waterfall of people using this approach for sort of various pathologies all across the country and essentially the world. This is the initial paper, 16 patients that underwent 20 of the transorbital neuroendoscopic procedures. The pathologies were variable: CSF leak, optic nerve decompression, repair of fractures, as well as 3 skull-based tumors. The two main goals during, especially when early on in describing a new technique, is it feasible from an anatomic and visibility perspective, and then the analysis of safety for the patients. So this paper was able to show that able to fix these pathologies with good exposure, good working angles, and essentially accomplish what the goal of surgery was. And then in the analysis of safety, there's no significant complications or treatment failures. So as a preliminary paper describing a new technique, this was a great success, showing both the feasibility, the viewpoint that you can have, as well as the safety for the patients undergoing the procedure for various pathologies. And as mentioned earlier, for minimally invasive procedures, cosmetic results are important, and I think that's a lot of push towards that for both patients and surgeons alike. So this is, once again, an early paper, came out a few years after that initial one, talking about a transorbital keyhole approach, really focusing on both the early as well as the long-term morbidity, and specifically the cosmetic results. The 71 patients, so a fairly large study, especially back in 2011. And what I thought was interesting in this paper, and I gave it some credit, is that at the 7 months, looking at the late morbidity, it was done by an independent examiner that wasn't involved in the case beforehand. Minor complication rates, which the early was 16.9%. A lot of those were CSF had subgaleal collections, periorbital swelling, periorbital hematoma, etc. Their major complications, which required surgical intervention, was 5.6% in that cohort, mainly for CSF leak, hematoma, and pneumocephalus. So the long-term morbidity, looking at the cosmetic results, they interviewed the patients, independent examiner, had a very good or good rating, almost 91% of their patients. So those cosmetic results are good for rated based on the patient's own experience. Now, looking at some of the current indications and the literature kind of got us to where we are today. One of the strongest is repair of CSF leak. Once again, you recognize some of the names here, as this really got its birth at the University of Washington. Published this shortly after the initial paper. 12 patients who had cerebrospinal fluid leaks. Half of those, 6 of them, they were had prior either endonasal or transcranial repairs and were still leaking. All 12 patients had successful stopping of their CSF leak with a single transorbital procedure, and they had 1 mild complication with mild anathemos. Fast forwarding another 10 years, once again, kind of echoing the success of that first study in 2010. Another group had 16 patients. Once again, many of them were revisions. All of them had successful repair of the CSF leak with a single transorbital procedure. Currently had a mean follow-up of 11 months, and they reported no significant complications. There's a recent kind of review of the literature that kind of combined all the CSF leak cases that were reported in the literature and found a 92% success rate for CSF leak repair using the transorbital approach, which is higher than a lot of transcranial, which the reported in the literature success rate is between 70 and 85%. Another application is the optic nerve decompression. This goes back even before the 2000 and 2010 kind of surge in transorbital procedures. Ophthalmologists use this a lot in the 1980s, really for transorbital decompression for patients with Graves' disease reported. And these are patients that cannot be managed with steroids. 12 eyes with vision loss, all of them improved with this transorbital optic nerve decompression. So even early on in the 80s, this was known to have some success. And then DeSoma, which is a name that you can see all over the transorbital literature, similar with Dr. Mo, did a really interesting anatomic study that was published in 2017, really looking at the endonasal versus transorbital approach to an optic nerve decompression and getting down to exactly how much circumferentially of the optic nerve can be decompressed via the different approaches, and to determine kind of which is best. So the endonasal approach, they were able to remove, it makes sense, the inframedial canal, or about 168 degrees of the canal, which ends up being just over 46% of the bone. Where you have the transorbital, you are able to remove the superior lateral canal, getting about 192 degrees of canal decompression, or 53% of the bony removal. If you combine those two, you can essentially get a 360 degree decompression of the optic nerve. The difference was statistically significant in their cadaveric study. And now moving on to skull-based tumors, which is where a lot of the applications are being used today, and where groups are kind of really starting to kind of stretch the bounds and see what is able to be completed via this transorbital approach. Unfortunately, most of the literature is still small, single center, case series. For approaches like this, it's hard to have anything of significant level of research. But doesn't mean it's not important. Is really looking at safety profile, as well as kind of tumor extent of resection, recurrence, things like that. So making sense, the sphenoorbital tumors that involve both the orbit as well as kind of the middle and sphenoid wing there are an obvious choice for trying to tackle with a transorbital approach. There's a few studies I'm going to highlight, recent publications, Dallin et al. in 2018 had a series of 14 patients that had sphenoorbital tumors. About 60% of them had intraorbital involvements. Everyone had proptosis of their patients, as well as half of them had double vision, and about half had visual impairment as well. Their main goal for this procedure, or for this paper, was that there's no major postoperative complications. Fortunately, they didn't describe the extent of resection or any long-term follow-up for that. And then in 2022, 35 patients in the Locati group, they were evaluating craniotomy versus a transorbital approach for these sphenoorbital meningiomas. And they had two results that I think are worth mentioning. Higher chance of a Simpson grade 1 or 2 with the transcranial approach. And you can see 76% versus 46%, which is statistically significant. But in looking at the transorbital group, they did have improved short as well as long-term postoperative KPS scores in the transorbital group. So there's positives and negatives to both that you can see there. You may not get you don't have a good as good of a resection, but patients kind of both in the short term and long term tend to do better. Other tumors that can be tackled through the transorbital approach, middle fossa, Meckel's cave tumors. There's been several publications recently on this, going back to Chabot et al., which is the Pittsburgh group. They looked at 13 patients with about 60% of them being meningiomas. 8 of those patients, the goal was gross total resection, whereas the other 5 patients were biopsy or debulking. In those 8 patients where gross total resection was the goal, 2 had it and 6 had near total resection. Proptosis was present in 9 of those patients and diplopia in 7, which improved in all the patients in the postoperative period, and there was no reported worsening of symptoms or major complications. Gian et al. In 2018 focused just on Meckel cave lesions. Had 9 patients, was able to report a gross total resection in almost 80% using the transorbital approach, and had a 0% CSF leak post-op. And in the name Dysoma again, in 2021, combined and simultaneous endoscopic endonasal as well as transorbital surgery for a Meckel's cave schwannoma. So as mentioned, most of these are all single center case series and not a whole lot of heavy evidence, but people are starting to kind of increase the indications and get good results, both from a tumor resection standpoint as well as a patient safety and morbidity standpoint as well. There has been several just kind of small case reports looking at anterior skull-based lesions, large olfactory groove meningioma, had gross total resection, no complications using a transorbital approach. Once again, that's just a single case report that was published earlier this year. In 2021, there were 2 systematic reviews that came out kind of in parallel. This one looked at both anatomic and clinical papers. For their criteria, 23 publications were included in the systematic review. And I mentioned it's the highest level of evidence for any of the papers they used was a level 4. Which kind of comes with the territory of, case series, case reports, things like that. Cumulatively, they had about 69 patients in their total group, and they reported, as mentioned earlier, a 93% success rate for CSF leak repair. There were 31 tumors in this group with the 71% resection, complete resection, gross total resection rate, and then mentioned too a length of stay of just over 3 days in the hospital, which is comparable, if slightly better, to transcranial approach for similar tumors. And then they reported cumulative 13% complication rate. 9 patients, 5 of them were in the CSF leak patients, either having a recurrence of their CSF leak or like orbital hematoma things like that. The other systematic review that came out that same year looked kind of broadened their inclusion criteria for the amount of studies. So they had 42, once again, it was both anatomical studies as well as clinical. I'll focus on the clinical studies here. They had 193 patients, and their kind of main showing for this paper was the cumulative rates for complications, as well as breaking those down. So as far as what type of pathologies these patients had, about half of them were meningiomas, 15% CSF leak, 11% were infection, abscess, inflammatory disease, and then had about 7% schwannoma. So there's a nice table where they list the complications afterwards, with diplopia being one of the highest. 23 patients. You can see the single series rates range from anywhere from 9 to 22%, and then the overall rate in total cases right around 12%, which is higher than a lot of the other individual studies, as well as what I've seen postoperatively. Ptosis, proptosis, peripheral edema, CSF leak, you can see those are all fairly low risk profile, 0.5%, 2.5, another 0.5. So overall, if you look at the overall rates in total cases, the morbidity of those complications and the rate is low. Once again, concluding that these can be safe corridor to access these various pathologies. As with any systemic review, there's a lot of limitations to them, one being the level of evidence of the papers are including, as mentioned, most of them level 4, as well as there's not a, it's not same throughout all the papers as far as what they're looking at. They don't comment on extent to resection. A lot of them are focused on mainly, is this safe complication-wise for the patients? So I'll kind of shift gears again, show another one of my favorite places in the world, which is Banff in Canada. Beautiful spot. If you haven't been there, highly recommended to take a hiking trip there. So now I'm going to review our data at the Medical College of Wisconsin, kind of looking at our experience starting in 2017 when our Dr. Zwargman, our skull base surgeon, started. We developed this multidisciplinary superior eyelid or superbrow transorbital technique using the microscope with the addition of the endoscope if needed, but mostly microscopic technique. And throughout the years, we wanted to further kind of elucidate the indications, show our clinical outcomes, and essentially complications of this approach. We can see the team there who are all involved in the majority of these cases throughout the last 4 years. So methods, as with most literature in this field, retrospective single-center chart review from the time we started doing these procedures in 2017 through June 2021. Of course, we don't have our most recent year of data between 21 and 22, where we did a significant increase in number of cases. I'll hit on some of those at the end. But these were all consecutive patients undergoing the microscopic transorbital resection of skull-based lesions via mainly a superior eyelid approach, but a few patients we did do a superbrow incision. It was a single neurosurgeon in collaboration with the oculoplastics surgical team. The majority of the cases were done by Dr. Hong, but there were a few that were done by various other oculofacial plastic surgeons. So I'm going to describe our technique briefly, as it's a little different than what's been reported in the literature, and just kind of give a sense of our rationale and what we're able to accomplish through this approach. So multidisciplinary, we always use our oculofacial plastics team for both the incision kind of exposure as well as the closure at the end. Position of the patient was supine, head turned about 30 degrees, slight extension in the Mayfield, similar to any kind of general pterional aneurysm type position. The incision, the majority of these cases, we did the superior eyelid incision, which you can see a photo there, using a natural crease. We did extend the incision 20 millimeters lateral to the lateral commissure, lateral canthus, and then we always put a corneal protector in place to protect the cornea. Once that was all set, the patient was prepped, then it's the oculoplastics team that did the eyelid dissection using the medial landmark of the supraorbital notch, their lateral landmark, the frontozygomatic suture, and then avoided any superficial dissection when getting up to the rim to avoid the frontal branch of the facial nerve. Once the skin was exposed and the orbit was visible, we did our osteotomy cuts. And this is, we used a sonopet with what we call the osteoemulsifier handpiece, which took place of a reciprocating saw. This is a great tool to have. It really makes nice, clean cuts, safe, I think more safe than a reciprocating saw. Didn't cut into the periorbita. So once we had this, it was kind of a game changer with our osteotomy cuts. The superior osteotomy was vertical, just lateral to the superior orbital notch. And then we'd always measure out the frontal sinuses as well to avoid entering the frontal sinus unnecessarily. The lateral osteotomy was horizontal at the frontozygomatic suture. And then once those cuts, the superficial cuts to the orbital rim were made, we pre-plated or pre-drilled for the orbital plating, essentially to ease in the reconstruction at the end. So we had a perfect cosmetic lining up of both the superior orbit as well as the lateral orbital rim. Once the osteotome, or once the sonopet cuts were made on the superior osteotomy and lateral osteotomy, that's usually when we, the neurosurgery team, would come in. We did a single keyhole burr hole, and then use a craniotome to connect to the superior osteotomy as well as the lateral osteotomy, and then osteotomes to finish off the craniotomy. So this is a combined, essentially, keyhole, transcranial, as well as transorbital approach. And at this time, the surgical microscope was brought into the field. Depending on what the pathology was, we would then proceed to drill and remove the orbital roof for anterior skull-based pathology, or take down the sphenoid wing, drill out the to get to the supraorbital fissure, take down the clinoid if we're dealing with sphenoorbital pathology. And it really gave us a viewpoint where we're working directly down the path of the tumor, where as you remove the sphenoid wing, you're working in tumor essentially the entire time, especially for sphenoorbital pathology, able to really decompress and debulk the majority of the tumor before even encountering or having to see brain. So there's absolutely no brain retraction during these procedures, which was very helpful post-operatively. So once the tumor was removed completely, we tried for a watertight primary closure if possible, obviously depending on patient's dura and as well as what needed to be removed. We would do then a dural substitute, either inlay and onlay, and then plus or minus an abdominal fat graft if deemed necessary to help prevent CSF leak. At that point, the oculoplastics team would come back in. They'd, with their pre-drilled holes in the rim, they would add 0.5 millimeter plates with 4 millimeter screws, reattach the orbital rim there. Oftentimes, the periorbital was still intact, even with removal of the superior orbital roof as well as the lateral orbital wall. We did not have to plate or repair the walls of the orbit. The temporalis and deep temporal fascia was then reapproximated with forovicryl, and then the lateral canthal tendon was secured with a foro Mercelian suture anchored in the superior temporal direction to the periosteum. And this is a very important step. Otherwise, patients would have kind of drooping of their lateral eyelid, which is not a desirable cosmetic result. Once that was done, a 6-0 Vicryl was used to close, and then 6-0 plain gut for the skin. Post-op care, which also I'll be hitting on a little bit too, is a lot of the patients went to the ICU for just one night, but many of them, especially in the later years, went to the floor. Part of this was due to kind of what was going on in the world, what was going on in our hospital, and having a limited resource of ICU beds during the COVID years. And for many of our patients, not just the transorbital cases, extraaxial tumors went well, patient woke up well. We were able to discharge them to the floor immediately post-op. And that's kind of was a change compared to the earlier practice we had, but found that with good nursing staff, that patients did very well and actually enjoyed being out of the ICU, getting a little bit more rest on that post-op day 0 and post-op day 1. We had all these patients on high-dose steroids, Solumedrol 250q6 while inpatient, and then did a 6-day taper on discharge. The patients were on antibiotics while inpatient and did oral Keflex on discharge for a total of 5 days. This was largely in response to what the oculoplastics team preferred. And then we also did topical erythromycin to the incision for about 2 weeks post-op as well. So getting to our numbers, in the first 4 years, we had 40 total cases. As I mentioned, in our most recent year, we had about 20 additional, which aren't included in this data set, unfortunately. The majority of these were from meningiomas, about 78% of them, which middle fossa, frontal convexity, sphenoid bone, anterior clinoid, as well as planum. You can see kind of the other spattering of cases, a couple of Rake's cysts, an astrocytoma, dermoid, the Meckel's cave lesion, a pituitary microadenoma, solitary fibrous tissue, etc. The length of surgery for all these ranged from 4 to 11 hours, with the mean being about 6 hours. And the length of stay was just over 3 days. It ranged from 2 days to 9 days, and that includes the day of presenting, the day of surgery as day 1. Looking at the patients preoperatively, the majority, 36 of the 40 patients were symptomatic on presentation, with 6 only having neurological symptoms, meaning headache, seizure, facial numbness. 11 only had visual symptoms, diplopia, proptosis, change in visual acuity or mobility. The majority of those had, 19 of the 36 had both neurologic as well as visual symptoms. Post-operatively, 72% of the cohort experienced symptom stability or improvement. I'll kind of go into that, especially the visual acuity, the next slide. And then, as mentioned, 28 patients who presented with deficits in their visual acuity. Over half of them had improvement immediately post-op, and even better, kind of looking at long-term results. So this is the vision results. The chart on the right is the change immediately from pre-op evaluation to the first, either while in a hospital or before discharge, or their first post-operative visit with the ophthalmology team. And this is looking at like a log MAR, which is the logarithmic of the median angle of resolution. It's kind of like a Sumlin chart for assessing visual acuity. And the difference in visual acuity, 0 means no change, a positive result means improvement, and a negative result is a slight decrease. But at negative 0.5, reaching that threshold is a significant change, and anything less than that is a very minor change on the chart. And that's all, as I mentioned, early post-op. 4 patients, so 10% of the cohort, demonstrate a mild decline on the long-term follow-up still, where many of the early decrease in visual acuity improved over time. There were no patients that had any complete vision loss. And then there were 2 patients that developed new cranial nerve palsies, one a third and one a sixth. both of which were mild, and the third nerve improved completely. So talking about our complications, total complications in the early period were 3, so 7.5%. We had 1 infection requiring a washout, 1 hematoma requiring surgical evacuation, and then we had a post-op seizure that then, due to residual tumor, eventually underwent a transcranial approach a few years later. All of these occurred within the first year to 2 years of practice, and we have not had any CSF leaks in all 4 years of the study. Cosmetic results, this is kind of like the long-term morbidity. 3 patients, 3% in the first year, and about 7.5% overall, did undergo delayed interventions for cosmesis with oculoplastics, none in the most recent year of the study, showing that kind of as we develop the technique, improvement in both the total complications rate as well as the cosmetic results. So kind of concluding with our initial publication is that this is a minimally invasive corridor that could be used safely in a variety of middle fossa, anterior skull base, and sellar region pathologies. But more importantly, the multidisciplinary collaboration has allowed us to develop this technique over time and minimize complications as kind of the technique gets modified over the years and allows for both good cosmetic as well as good clinical outcomes. The next steps to kind of the team at Medical College is looking at is kind of long-term tumor control, extensive resection, as well as patient satisfaction, like years down the road via this approach. And it was kind of interesting after, during the last couple of years where we started doing a lot more of these cases. A lot of the patients would come to us and be like, I heard about this minimally invasive approach. Is this something that you do for me? So patients were seeking this out, even as if they got opinions at outside hospitals, chose to kind of see what their options were via the transorbital approach. And here's Dr. Shaker showed a couple pictures of Lambo in his introductory talk. These are some pictures that I've taken over the years. Really needs no introduction. It's one of the greatest places to watch a football game. And if you ever have the chance, I'd highly recommend it. So now with the little bit of time remaining, I'm just going to hit on a couple of case examples. I'll try to get through as many as I can. Please feel free to ask questions and interrupt as I'm talking about these. These can be more of a discussion as I go through these. These are a lot of the cases that were included in the study, as well as a few that were done in the most recent year. As we developed our technique, we were able to do more extensive tumors, and that kind of shows as I show you these different case examples. So this was a 75-year-old or 73-year-old female, came in with headaches and decreased visual acuity, had a prior surgery years ago at an outside hospital. We didn't know pathology at that time, presumed meningioma. We offered and discussed a transorbital approach. They seemed eager to do that. Length of the surgery was 6 hours. Spent 1 night in the ICU and then was discharged on day 3. You can see the pre-op imaging here. We have a coronal and axial post-contrast, as well as the bony window here with the kind of enlarged anterior clinoid, as well as the evidence of a prior craniotomy in that location. So post-operatively, you can see the post-op axial CT showing the extent of the bone we removed, essentially all the lateral orbital wall, anterior clinoid, and then the MRI, both contrast over long-term follow-up, has not shown any recurrence or evidence of residual disease. Another case, this guy, 74-year-old male, had a pretty extensive neurosurgical history already before coming to see us. He had a prior pituitary adenoma resected transcranially back in 1997, was panhypopit. Also had a prior right MCA clipping. So had several transcranial procedures and was not eager to undergo another one despite having this very large olfactory groove meningioma. We discussed the potential of tackling this through a transorbital approach, going through the superior orbital roof. And that's like what we elected to do, knowing that we might not be able to get the entire tumor out via this approach. The length of the surgery was 10 hours, so a little bit longer. Spent 2 days in the ICU, and he was discharged on post-op day 4, very satisfied, no neurological deficits. We had no brain retraction. And that's one of the reasons too that we approached this via the transorbital approach, given his multiple other intracranial surgeries in the past and risk for essentially causing bifrontal injury going transcranially here. We don't have a post-op MRI. This is one of the more recent ones, but this is the post-op CT immediately. You can see evidence of his prior cranies, and then through his left orbit, that small superior orbital cut and the lateral orbital cut is what we used to approach the tumor. This is another example that presented 66-year-old, had a right sphenoorbital meninge, once again had a prior resection back in 2012, was having decreased vision for a couple of weeks and essentially was only able to see light and shadows. So presented to us pretty late. Mostly bony involvement, as you can see, with also some intraorbital involvement as well, and pretty significant proptosis. He did really well post-operatively. He was discharged on day 3. Last follow-up, his vision was unchanged. He had pretty bad optic nerve atrophy, but there was no worsening. He had improvement of his cranial nerve 3 palsy and then stable V2 numbness as he did pre-op. You can see the extent of the bony removal there. And this is one of the ones we use a brow incision with good cosmesis afterwards. This is another case here, 81-year-old with progression on imaging. She too had a history of prior bifrontal craniotomy. So once again, we discussed tackling this with minimal brain retraction, given her history of prior frontal lobe injury. You can see there's some gliosis there. Length of surgery was 5 hours, spent 1 night in the ICU and discharged on day 3. Gross total resection on MRI, and then this coronal view of the CT really shows the orbitotomy that we did with the lateral plate there, and the superior cut right at the supraorbital notch. Here's another meningioma that was tackled. This is a anterior clinoid meninge, 78-year-old, worsening vision, had double vision, had headaches, underwent the transorbital approach. Length of surgery was 4 hours, spent 3 days in the ICU mostly because of other medical comorbidities, and then was discharged on post-op day 4, doing really well. See, showing some of our successes before, and then some of our maybe not complete resections here. You can see the CT scan shows the amount of bony removal, but there was some residual that we left, which was medial to the optic nerve. We didn't feel, given his age, that putting the optic nerve at more risk to try to get that was necessary. This has been stable on follow-up imaging afterwards. It's something that we're keeping an eye on, and goes to kind of what we want to look at next is the extent of resection for a lot of these, as well as kind of long-term tumor control. This is one of the interesting ones. This is a cyst, a cellular cyst, 57-year-old, presented with bitemporal hemianopsia. He also had a prior history of transnasal as well as transcranial approaches at an outside hospital for this years prior. Had bad experience with transnasal and having a CSF leak, infection, meningitis, so really did not want to go transnasally again. We thought transcranial approach may be a little excessive. So we offered transorbital for fenestration of the cyst. Length of the surgery was 3 hours, ICU overnight, and then discharged on day 3. Immediately had improved vision, and then has not needed retreatment of this cyst, but once again, is something we'll be following for. Here's the post-op MRI. Comparatively, it shows decrease in the cellular cyst there. And then a couple more minutes, then I'll open up to questions. This is another kind of anterior skull base lesion, presents with blurriness in the left eye. This is one of our more recent ones. Went to the floor immediately post-op, discharged on day 1, and is doing great. Had a gross total resection on post-op imaging. And then another olfactory groove, a little smaller than our first one I showed. Postoperatively went to the floor. He presented with a seizure. He was also discharged on day 1. Don't have a post-op MRI yet, but we did feel we got a gross total resection for him as well. And then finally, another kind of sphenoorbital meningia was growing on interval imaging. This one also went to the floor immediately post-op and was discharged on day 1 with a CT here showing the montoboni removal, as well as the coronal CT scan showing the orbitotomy and reconstruction there with good cosmetic results. And finally, basically, another thing I like to do is golf, and that could be anywhere. This is Whistling Straits here right in Kohler, Wisconsin, and the top left is the Irish course there as well. So I want to give special thanks to my mentors at MCW, Dr. Zwargerman, who's the head of the skull base and pituitary department there, Dr. Kerpod, Dr. Mueller, who has a history here as well, and is one of the greatest people and surgeons that I've had a chance to work with, Dr. Hong through the oculoplastics department, and then Christina Feller, who's a great 4th-year medical student who's applying for neurosurgery and really did a lot of the groundwork for the paper. And obviously I want to thank the University of Washington for allowing me to complete my fellowship here with Dr. Shaker, Dr. Frera, Dr. Ellenbogen, Dr. Ruzovic, and as well as I want to thank the residents who have all been a pleasure to work with over these last 4 months. I learned a lot from them. I hope they learned something from me as well. And last but not least, I want to thank my strong supporting cast at home. I have 2 wonderful girls. Riley's 2.5 and Ada is 7 months. And then I have a very food motivated 5-year-old chocolate lab.